Hello, everyone, and welcome to Tales from the Trenches. I'm Stephen Collins. I'm the CEO of Matter. We are a healthcare technology incubator and innovation hub built on a belief that collaboration between entrepreneurs and industry leaders is the best way to develop healthcare solutions. Today's program is part of our Tales from the Trenches series, which features accomplished healthcare entrepreneurs sharing their learnings and stories and takeaways from their journeys. We have a great collaboration with VillageMD to produce this series. For those of you who aren't familiar with them, they are a Chicago-based company that's innovating in value-based care, operating in 10 markets, and they work with physician practices to implement true value-based care models. Our guest today is Aneesh Chopra. Aneesh is an extraordinary entrepreneur and a technology leader who's played a really key role in designing the United States' relationship with healthcare innovation and data. He was the first ever CTO of the United States, serving under President Obama from 2009 to 2012. He previously was the CTO of the state of Virginia under Governor Tim Kaine. He's the author of Innovative State: How New Technologies Can Transform Government. And importantly for this conversation, in 2014, he started a company called CareJourney, which is a digital health company on a mission to make healthcare data more useful. He also serves as a senior advisor with the Albright Stonebridge Group, which is a consultancy chaired by former Secretary of State Madeleine Albright. Our moderator today is Mike Roberts, the Chief Technology Officer of VillageMD. Mike joined the company in 2016, and he and his team, as I said, they're truly at the heart of enabling value-based care solutions and allowing the VillageMD to scale. So before we start, I just have two quick housekeeping notes. One is if you have questions you'd like to ask Aneesh, please use the Q&A function of Zoom, and Mike will weave those into the conversation as appropriate. And second, if you opted into the post-event virtual networking, you'll receive an email shortly from Kay Nietzkaj with a separate Zoom link. Please use that link to join us when the main program ends. Aneesh, thank you so much for joining us today. Mike, thank you so much for not only joining us, but facilitating the conversation. And I'll turn it over to you to kick things off.
Awesome. Thanks, Stephen. Excited to be back. I think this is my second time. I certainly look forward to today's dialogue. Frankly, probably the best part of my week. At least that's what I'm hoping for. Aneesh, how are you? It's good to see you.
No pressure, my man. But yes, we're going to have a great conversation. Great to see you as well. Thanks, Mike.
Yeah, of course. So I've gotten to know you over the last 4 or 5 years reasonably well. And I've just been blown away at the level of passion you have for disruption in healthcare. But I'll be frank, your journey that's gotten you here thus far is quite unique. And as you've seen a lot relative to both the private and public sector, I'd love for you just maybe to describe a little bit about that and what's led you here.
Well, I'm generally I'm passionate about problem solving, Mike. That's my, when I was young, my dad's college buddy launched a kind of a technology company from a farm in India, came to the US as a graduate student, became an expert in telecommunications, the switch from analog to digital. In many ways, got lucky. And after he successfully sold his business, he decided to get into the problem-solving business and went to India with a penny a year salary to say, I want every family to get access to phones. At the time, India had 300,000 telephone lines on a country of 300 million people. And if they simply accepted the Western technical architecture, it would have been a multi-billion-dollar journey, and they never would have gotten there. And it would have been huge political debate about taxes and market forces. He actually found a way to solve the problem through innovation. He built a brand new de novo technical network as an open stack. The government funded the engineering, built some of the intellectual property, and then open sourced it to a new marketplace of entrepreneurs and innovators who could build the last mile. And within a decade, they had every single rural village connected to the phone network. And that was in the 1980s. Mike, I believe in this generation, reining in healthcare inflation to allow for American reinvestment for the industries of the future is the issue of the day. So it's not just because we want to fix healthcare, it's good for society. And I deeply care about improving health outcomes for every American, there's also an economic competitiveness. I want the economy of the United States to thrive, and the two are highly correlated. If we can constrain the rate of healthcare inflation, we can reinvest in the industries of the future. And that formula will be how we compete over the next 50 to 100 years. And so I'm motivated to solve problems and grateful for the chance to do so in what is obviously a significant sector of the US economy.
Yeah. Actually, I didn't know that about your family. So that's one thing that was just really exciting to hear. Thanks for sharing that. I know why you think the way that you do, I think in many ways, as you described that. So one of the aspects that one part of how you've been both innovative and entrepreneur in terms of your path hasn't been limited to just the public or the private sector, but you've sort of interwoven the two, which from my view is so incredibly important as we think about the change that you just described, which is not about, lowering the GDP of healthcare. Of course, that's one of the outcomes, but it's also about a competitiveness in the global economy. Maybe if you can describe a little bit more specifically about some of those twists and turns along the way that sort of led you to this level of passion that you do have as it relates to driving to innovation and change.
So you take that weird turn out of college and you end up at Morgan Stanley as an investment banker. So you're like, how does a public policy guy with an interest in healthcare show up as an investment banking analyst, out of college? And the reality is I wanted to understand capital markets because they are a uniquely American muscle in terms of bringing about new ideas. And so I was on the healthcare team, but my colleagues on the tech team took a little old company called Netscape public. So I'm dating myself, Mike. I'm a bit older than you. And so Netscape going public was this sort of watershed moment. There's this thing called the internet, and it's going to change everything. And sort of I got religion about this thing called the internet, and it was going to change everything. And when I went to graduate school, the Kennedy School, I decided to focus my master's thesis on how we can apply internet-based technologies to the healthcare sector. I then took a more traditional job out of graduate school where I joined the advisory board company. Many of you were members of the advisory board. We felt like it was a cute little happy oasis for best practices research and a place for us to think. And I kept asking the leadership team, we got to focus on the internet. We got to focus on technology, even though our members hadn't been asking. So I got permission to write one study. We took it around to get member feedback, and there was a lot of interest in how we can use these new technologies to solve problems. So I spent that time at the advisory board. We were blessed with a company that was growing. It went public. I was on managing director, what have you. And that gave me some freedom to then get into the government where I served, focused on healthcare IT, but at the state level. And while I had a broader mandate to look at transportation innovation and educational technologies, I was passionate about that healthcare IT component and witnessed sort of stage one of health interoperability with HIEs and all the rest. And then as I went into the Obama administration, we were just obviously with the Recovery Act all in on three things in healthcare: making sure that we digitize the medical record, making sure that we open up as much data as we collect in government and regulate, and then obviously the sleeper cell, making sure that we can actually focus on driving payment reforms to reward the use of these technologies for the betterment of patients' outcomes, financial and quality. So I've been in and out of the government, and I would say I'm in the private sector and I will wear a private sector hat, but I'm skirting right up to the edge of the government as we'll go through today's discussion, believing that the public-private interface has the highest leverage for impact in this journey to modernize the system. And we're going to do our level best to maximize the value of that public-private I call it handshakes and handoffs, where we've got relatively bipartisan views on this set of issues: standardizing data, opening it up, regulating the EHRs, the data systems, and moving to value. Let's maximize those, where we all agree, and maximize the impact neighborhood by neighborhood. So that's the journey, Mike. It's trying to find this sort of technical muscle as an innovation fuel and applying it to our sector.
Fascinating. Thanks for sharing. And I do want to get to a lot of what you just said, especially as it relates to the last 5 years in our journey, because I think the level of this handshaking that you are seeing between public and private sector is at an all-time high, personally, and I'd love for you to opine on aspects of that. Before doing that, though, I'd love to go back to your time in the White House and on Capitol Hill. And
Yes.
that's such an extraordinary thing for me and for us, I think more broadly, to be talking to the first chief technology officer of the United States of America. That's not lost on me that that's also my title and just happens to be at VillageMD, and that's very different than these two are sort of very different. So I'd love maybe just to describe the magnitude of what that sounds like and how that translated in the day-to-day of actually having that role.
Yeah. So President Obama had a unique passion for this subject. And I just happened to be the first to fill in a vision he already laid out, which was a belief. First of all, he had a philosophical view that change is bottom up, not top down. Let's just start that. I don't mean to make any political statements about one being good or bad, but that was his philosophy. And by saying I want bottom up change, there was a natural need to leverage technology, data, and innovation to reach the larger population in ways that you just couldn't in traditional organizing. And so he had an intuitive sense that we're going to take advantage of these new technologies. And frankly, as he was walking into the White House, a sense that the policy implementation up until that point likely wasn't maximizing the value. And he'd seen it firsthand in his campaign, which is a microcosm, but maybe we hadn't seen the fruits of it. So I was on the transition team because Virginia had think of it like minor leagues to the major leagues. I was in the governor's cabinet. So you might say, oh, look, we have CIOs and they're technical people and they can implement, change, and they buy servers and they make systems work. And so we had a professional CIO, and some states were experimenting with putting a person like a CIO in the cabinet. The role in Virginia was a little bit different. They didn't want the engineering team to kind of make policy changes. They kind of wanted the engineering team to just execute the job and do it really well. But they wanted a policy advisor to say, as we were making decisions on regulation, investing in programs, implementing policy, that we took full advantage of all that we could. So we weren't leaving capability on the table. We were maximizing the value. So the joke with Governor Kane was that I was CTO in kind of conceptual terms. I was really chief collaboration officer. And so when President Obama named me, he did a couple things structurally. It had nothing to do with me. I'm a nobody. But he created this role as an assistant to the president, which means it reported directly to President Obama. And these two policy councils that were critical to healthcare reform, the National Economic Council and the Domestic Policy Council, mostly were made up of members of the cabinet, but a few staff members. And he put me as principal, for lack of a better term, on both of these bodies. Again, I could never tell the experts in health policy how to maximize incentives and figure out where the math is on expanding access, but I could be a little bit more swimming in my lane. Here's where the technology, data, and innovation implications are if we twisted this versus that. And that was the role. So the role was wake up every morning, identify the priorities that the president laid out, execute the horizontal muscle of technology, data, innovation, and then flywheel as much as we could. And as you could imagine, Stephen is such an awesome recruiter of talent. He brought Todd Park, my successor. Really, the most important thing I did when I left the administration was making sure Todd was my successor. And I frankly think that was the greatest gift to the administration, to have Todd, because you have an execution arm who could scale up some of the experiments that we ran in the first term. But that idea carried forward in the Trump administration. Actually, he had handed this sort of role to kind of split the role. Jared Kushner, his son-in-law, had a piece with the Office of American Innovation, and then he had tasked a more proper a chief technology officer. And my point in saying this is that we had a bipartisan view, and now, of course, the Biden administration is embracing these same muscles as it goes about its work. We just saw this week the Senate confirmation for the science advisor, my old buddy, Dr. Eric Lander, who's made sort of the same philosophy bedrock into the role he's going to play in the administration.
Yeah, so that's amazing. I think quite fascinating always to hear more about that. Maybe going from that as this, I would argue, genesis of many of the changes that are coming to fruition today. So we've seen info blocking rules. We've seen the standardization using FHIR. We've seen opening up of data sets, the things that you're mentioning. Maybe talk a little bit about like how that actually happened, because it didn't happen right away. Things needed to be digitized, and then people needed to get their head around it. People needed to agree. So it's a journey to get there. But I'll be honest, it does feel like the flywheel is starting to turn pretty quickly on these things.
So I'll step back and give you context, which is the U.S. has a very unique policy approach to technical matters. We rely on industry consensus before we dictate regulatory action. And where there's industry consensus, we can scale it up through regulation. But where there's not consensus, we face a sticky wicket, which is how do we standardize something when the industry stakeholders don't want to? Now, in the Recovery Act, I'm just going to give you a tale of three markets: banking, energy, health, all three of which had digital transformation on the agenda. In the energy sector, we were installing these smart meters into everyone's homes. Think of them as electronic health records, but for your energy consumption patterns. On the banking side, we were digitizing checking accounts, and we were enabling data sharing so that you could use mint.com to access your bank. In all three, digital transformation, we saw three completely different frameworks for how we would get to standardization. In the banking sector, we never had to write a rule. We have rulemaking authority. There's information blocking authority in banking. Never wrote a rule. Why? Because the industry self-organized, and even if they didn't want to have quote unquote disruptive fintech accessing the banking systems, the norms in that sector are that they've worked together and they standardize, and begrudgingly, if they didn't want it, but they did it. They've opened it up. I remember vividly, JP Morgan CEO Jamie Dimon one day cut off mint.com claiming a cybersecurity risk. He got a call from the regulator the next day, Richard Cordray, who said, "Do you want me to issue this reg? Or are you going to fix this?" And in fact, it was true. They went from screen scraping technology, which Mike, is a security threat, and they upgraded to this sort of OAuth 2.0 technical standard that allowed for safe, secure sharing. By the way, the same anchoring technology to the Smart on Fire regulation. So banking self-organized. The energy sector, we put a small amount of money, maybe $10 million, and we facilitated. What we didn't want to do is you have a Chevy Volt in Chicago charging in your home, and then you drive across the way to Indiana, and they chose a different technical stack and it was incompatible. So you couldn't charge the Volt because somehow Tesla got in and made a proprietary Tesla connector. So the industry got a bit of a jolt, but that one-time funding was enough to get over 1,000 stakeholders over the course of several years agreeing on 20, 30, 40 technical standards that seemed simple, but they engaged and they scaled. They never had to replenish the 10 million. Health, Seema Varma said it best at HIMSS 2 years ago, Mike. When we regulated the EHRs, we said, what is the minimum data set we can get you to launch on day one? Let's get the meds list, the problems list, maybe a few other definitional things that were structured, and say, hey, industry, this is the minimum data set. We published it in 2010, Mike. You should self-organize and fill out the medical record. By 2019 or 18 or whatever the date was when she stood on the HIMSS stage to announce the rules, she said, I'm doing this because she said something like, you made me do this. The industry didn't add a single variable of data above the minimum data set. Now, she said, we're going to have to move. You've made me become quote unquote big government. We're going to regulate you. And so now we've got, begrudgingly in many ways, a requirement to get to the entire medical record over the next 3 years. So now there's a flywheel, but really only after rulemaking and heavily contentious debates about this. And so a really interesting dynamic across the three industries where I was involved in digital transformation to see why healthcare so far behind consensus making. Yeah. I'll give you one more final vignette. I'm going to just say thanks to Dr. Bud Tribble, a physician who serves as the chief technology officer at Apple. Because if Apple Health, when they launched, chose an Apple process to extract the data, they might have convinced a lot of the vendors just to go with the Apple way, because you can't have your car now has to have Apple Play in it, whatever. So they could have done that. But they chose to embrace this very early smart on fire technology before really it had any traction. Faster, frankly, as you know, Mike, than the rest of us that are in the interoperability space. If Apple doesn't do that in 2016, 17, whatever the dates were, through something called the Argonaut Project, I don't know if we would have made as much progress as we have now, because that forced everyone towards one common connection point that was open and substitutable. And here we are, building on that initial consensus roadmap. And I will say thank you to Epic, thank you to Cerner, thank you to Allscripts for participating in this industry standards effort. Maybe a little bit too begrudgingly, a little bit too late, but we made it. And now we're here and we're working together.
Yeah. That's great description. Maybe to double click on one thing that you had mentioned relative to, it took the lag time between 2010 and 2019, and what Seema said, and I remember that as well, as you made me do this. Do you think structurally between public and private, we have the right set of, from a technology standpoint, features in place, be it whatever that structure might be, and if not, what do we need?
So we still have this bizarre world where everyone's data sharing requirement is its own thing. We need a technical standard for prior authorization. We need a technical standard for prescription drug pricing. We need a technical standard for, it seems like we've got this litany of technical standards that we need, when in reality, we need one reusable framework, smart on fire, and we need to make it work. And any data element we need needs to map. So I'm trying my best, Mike, to get all these well-intentioned stakeholders who are moving in lots of different directions to say, guys, 21st Century Cures Act is law of the land. Information blocking are the rules of the road. Let's fold everything on top of a common stack and reuse as much of the infrastructure as is humanly possible. We don't need 5 years, and we're in the middle of this right now on public health reporting. We don't need a 5-year journey on a technical standard for a separate public health reporting system. We want to reuse the same infrastructure that VillageMD can tap to bring patients on board and to manage their conditions, as we would need to report COVID positive cases to the authorities. And that concept of reuse and building off of a common open tech stack, I think that's still a mental shift. We've got to get more of the industry to embrace. And we're seeing it right now, in addition to public health, on price transparency. So everything has to be its own technical standard. No, fold in one team, one stack.
Yeah. Fascinating. So maybe just to pivot a little bit towards how does this ultimately get funded over time relative to these innovative changes? We've talked a number of times about innovative payment models and this sort of convergence on taking on more and more risk as a provider and really focusing on managing the total cost through the lens of treating people better. From my view, the work that CMMI has done and the work coming out of sort of your where you live is just quite transformative. And I'm not sure that everyone maybe necessarily understands all of it. So if you can maybe just describe and give your perspective, because I think it's so fundamental to change the dynamics around what the funding levels look like over time is pretty dire if you don't sort of make these type of changes like yesterday, but at least we're making them, I think, now. So maybe just describe your perspective.
I'm not here to scare anybody, Mike, which I think you teed me up to sort of scare people, but let me just say the Medicare Trust Fund is running out in the not too distant future, okay? Or it's going to fall into the red. So we have to find a way to rein in healthcare inflation. The world is divided into two camps. I'm in the religious movement that believes we can actually accomplish that mission objective by delivering better care at lower cost. We actually have enough inefficiency in the system swirling that if we rooted it out, we can come back better, faster, stronger. I'm in that religious camp, okay? But the other camp is like, oh, look at the fodder over there. These nice, happy people are running experiments. We know the answer to this question, slash the rates. These people are paid too much, okay? So door number one, let's just call it the sort of evil door. It's slash the rates, go through another round of Balanced Budget Act all over again, and pain, and we're all disaster land, okay? Door number two, the happy land, the hand of collaboration, the hand of working together. It's how can do we believe all of our neighbors are getting the best possible care at the best possible time at the best possible rate? We know the answer to that. It's no. And what's powerful about this moment is if we can tune the rules of the road, we can put the entrepreneurial spirit of the country to work on how to route people more thoughtfully through the system. Do we bring them in earlier for preventive services? Do we monitor them more actively while they're home? Or do we wait for them to call us when they're in need and then try to manage them in a better way at the time they call? I don't know. I'm not smart enough to figure out which mixture of the portfolio is going to be more preventive, better monitoring, better action in real time when they show up. But I know that good people are going to work on it, and may the best teams and approaches win. So what we're doing right now is we're experimenting with how do we arrange the business model. Should the U.S. government, like Medicare Advantage, write a check that says, hey, you take on the responsibility of this patient, take the check, and you manage it. We've had a decade or so of experimentation, and early results clearly suggest it's better for patients. They get more supplemental benefits, they get better care, but at a price. They give up their original Medicare benefit. So now the question is there a Goldilocks? If we've got unmanaged fee-for-service where you can kind of do whatever you want, but you don't really access the services you need in the timely manner, or you have to switch to MA where they can manage it, but you got to give up your benefit, is there a third option? And I think, Mike, I'm more bullish on direct contracting, or a version of it that the Biden administration will iterate on that emphasizes health equity. Whatever the formula will look like, if we can allow individuals to retain their Medicare benefits, but to participate, maybe even opt in to a risk-bearing network that can help them navigate more thoughtfully and without taking away their choice of doctor, maybe we can actually move a model that can scale across the entire country. So you're not even in the first inning. We could turn to you. And Mike, what's your experience in this? You're like, yeah, I've been live for 3 weeks, so I don't know yet. We're not there yet. So no pressure on you. But I do think there's a huge bet that capitating primary care and networks, allowing you a lot more freedom to pick and choose what you want to pay a premium for, what you might want to discount, and to engage patients in a way that a passive Medicare benefit just doesn't do, might we do a much better job? I'm bullish, and I'm, again, wearing my CareJourney entrepreneur hat. I'm here to monitor all the data that flows through the CMS system to track what's working and what's not, and to scream at the top of my lungs if there seems to be an emerging strategy in a given market that needs to scale.
Yeah, no, awesome. So let's spend some time there, because we haven't gotten to the entrepreneurial side of what you're doing today and where you've been focused. One of the areas, I should say, you've been focused in the last several years. But it really, my view is, and full disclosure, VillageMD is a customer, but my view is you launched the company with the belief that it was at this grandiose level of being globally competitive through better policy, open data, better standards, et cetera. And this was how you personally and your team was going to try and have the greatest impact. And so when you talk about the open data sets and the reporting and the visual analytics, all the things clearly important, but I think it's really, really sustained from this sort of perspective that's really much bigger than that. Having said all of that, maybe just describe a little bit about how CareJourney how you started it and how it's changed over the course of the last 7 years as more of these things have actually come to fruition.
Yeah. So my view is, and I felt this then, I feel it now, the Medicare claims database, which is not beholden to any vendor, it's not proprietary, it hasn't been aggregated through clearinghouses and other means. It is an open resource. And buried in that database are the keys to learning what populations are getting great care, which ones are getting not so great care, who's quarterbacking that care, how can we scale it? It's in the database. It was illegal in the Obama years, coming into the Obama years, for anyone but an academic researcher to touch it. It was too sensitive. Not only was it sensitive, it was seen as privacy for the doctor, because you could look up any doctor in America and find out exactly to the penny how much Medicare paid. By the way, highest paid doctor in 2015, when the Wall Street Journal took the data set and published it, $11.1 million. That's a lot of E&M visits for a doctor, by the way. And it turned out Part B drugs was the driver. We'll get into that later. So the theory was this resource should be made public, but it's so sensitive for privacy reasons. You can't just like put it on the internet, individual patient level detail, that we had to have a gating function. And the market, I felt in 15, 16, 17, when we were thinking about this business model, I thought there were really two theories of the case. We'll call one the rent-seeking theory and the other the democratizing theory. And that meant, hey, I want to be in the data business, and I'm going to acquire data from every which way from Sunday. I'm going to clean it up, normalize it, and make it the easiest database to access. But man, that's an expensive thing to do. So I'm going to have to charge a lot of money for someone to be able to tap it in order to get insight, which largely meant the incumbents, big pharma, stakeholders that may not have been as motivated to drive the change would have been, it's like a sort of inverted problem, which is the very people who are going to have it may not be the ones that are going to lead the revolution. And the people that would, individual doctors, physician networks, startups, they don't have the capacity to fund a massive data project. So I thought, is there a business model that allows for a little bit more democratization, a little bit more open philosophy? And we settled on the theory that to solve the competitiveness issue, we need a Village to succeed. We need Allscripts to succeed. We need Oak Street to succeed, just to name my friends in Chicago. We need Rush Health System for health to succeed. We need the stakeholders to succeed. We just know that in all of their teams that are on team reform, they would like to tap the data set to learn about their markets. So how can we do something that works? And the answer was reusable library of insights. And so our philosophy was, let's build one open scorecard for every doctor, facility, network, market, and then syndicate. So you may compete vigorously with some of the names I mentioned, but you're both, if you're CareJourney members, you're going to access the same information and hopefully compete on how you use the information. And that may result in more surgical refinement of strategies. So we're not waiting years and years to determine whether that one intervention actually made a difference. We can't wait the 17 years from bench to bedside that we've seen historically in change in healthcare. That needs to be 17 weeks. And so we've got to do a better job. So that's the philosophy. I'm grateful that more data sets are being added to the open domain, Medicare Advantage encounters, Medicaid encounters. And so we will start to see, the dream is the bipartisan lower healthcare costs proposal that never went final, called for a kind of a commercial version of the CMS data cloud, where we'd have like a commercial cloud and a government cloud, and we could tap both clouds in order to make sense of it. I'm looking forward to that day, and I'm working hard to bring that vision to life.
Awesome. So maybe let's spend a little bit of time. We've got a number of entrepreneurs on the call. And I have to imagine part of what's going through their mind is we've got all this policy disruption happening, and this flywheel has started, and I've got my business that I'm starting or growing and hopefully going to be a successful business. As you think about the opportunity that exists for continued disruption, how do you think about where that opportunity comes from? How, as a sort of individual or a small set of individuals that are trying to disrupt and be impactful? Obviously funding is one thing, but it's not all about funding. I know for a fact it's not all about funding, and we've talked about this. And so just tell me a little bit about like, how do I be successful in the current state as an entrepreneur from your standpoint?
Hug a risk-bearing physician with love. My sense is physicians were trained in medical school to think broadly about the patient's needs. And then as we got into the business of medicine and the data sharing was hard, they could only do with what they had in their hands. So if the patient only came to them for back pain for this one acute episode, but they didn't have a lot of the context around what they tried in the past, who they visited, what was diagnosed, what was not, you didn't have the full picture to be able to make thoughtful determinations. The idea of hugging a risk-bearing physician is that those are the folks, when given access to information, are the ones that are spitting off all the things they would do if they had the chance. And that could splinter off into management service organizations or networks. It could mean niche services, like I'll be the remote monitoring team to support you. I can be the telemedicine on-call service that has the specialists ready for you if you need a quick consult, so you don't have to have a referral out, but you could just get the answer. There are a litany of use cases yet to be born, and entrepreneurs on this webinar, we hope, will run hard and fast at each of these niche problems, because it's going to be thousands of niche solutions. We're not going to have the one startup to rule them all. No offense, Mike. That will just be the answer to the nation's healthcare conundrum. There will be many, many component parts. There may be a few systems integrators that have figured out which are the best of those that are there to bring them to scale. But really, there's so much wide space for improvement. And as Todd might have said on the webinar, I got to double check, Stephen, but what he used to share publicly was that, it's not that there's low-hanging fruit in this move to value. It's like on the floor, you're stepping on the fruit down the street, right? It's just, there's so much, relatively straightforward stuff. I'll give you one small example. We put out this $1 billion innovation challenge before I left the White House. It came out of the Innovation Center, and we put out this, hey, who's got an idea? And, hundreds of people applied for grant funding, what have you. The YMCA submitted the program they've been running for years called the Diabetes Prevention Program. And they said, look, we think if you are pre-diabetic and you enroll in our course, you'll lose the weight, you'll keep the weight off, and you'll stay healthy, avoid full-blown diabetes. We funded a trial, maybe $7 million on whatever the number was, and 5,600 patients enrolled. And the actuary said, whoa, 4-to-1 ROI. People that enrolled in this program lost 5% of their body weight, never got full-blown diabetes, and kept it off. We should fund this everywhere, and we could include a pay for outcomes. You get paid something for enrolling in the class, but if you get the weight loss, the YMCA should get paid more. Wow, 2018, every doctor in America with the stroke of the actuary's pen had the ability to score, to refer every single Medicare patient to the YMCA. It's 2021. How many pre-diabetic Medicare fee-for-service patients have been given the $600 voucher to get the clinic? Forget whether they actually got the benefits of it, just even started. Thousands out of a base of millions who are eligible. How many seniors are aware that that they even have this option? How many physicians are aware they could prescribe it? It's in the Medicare program, funded, trial, scaled. Right. So entrepreneurs are going to solve that problem. There'll be, lead gen for YMCAs that can connect them, and they get paid a nickel for the whatever. We'll figure it out. That's what we need more entrepreneurs to run towards.
Yeah, that's awesome. One of the things that you had mentioned about the current administration, but I think it all resonates with at least those that have a passion about healthcare, is the efficient and the equal access of care. So be it in the rural areas of America or in the denser population in the urban areas of America, there are plenty of healthcare deserts that exist in many forms and fashions. And I know you have a particular passion as it relates to both the public and private sector in terms of that being addressed. I'd love for you just maybe to riff a little bit on that, given that I do think that there's disruption opportunity in that space as well.
If you live in an economically distressed neighborhood, you are a third less likely to be enrolled in an ACO than if you lived in a wealthiest neighborhood. The very people we need to bring care coordination to fall through the cracks. Why? Either the physicians they rely upon don't enroll in these models, or worse, their patterns of utilization fall through the quote unquote attribution formula. And so structurally, the very people we need to provide care coordination for aren't in the program, and we need to learn why. But that's not a widely reported, statistic. It sort of, now with the Biden team asking for these sorts of reports to be published, we're able to see more of this, and our team is running a lot of this. So my view is we have a paternalistic view of value-based care, which is get the doctor to enroll in the model and all their patients come with them. I think Liz Fowler has said, the CMMI director who's currently in charge, I want to move to more of a consumer-facing version, which is we want more people to participate. I believe the future will be some mixture of risk adjustment or incentive tied to recruiting folks that may not have stable PCP relationships to come into your networks, to manage their care, and to coordinate it so that we accomplish the mission objective. Think about the dual eligible seniors. And, oh, hey, Esther, I see a question from Esther. She's my fairy godmother of good energy. And so she's posed a question in our chat. We'll get into that hopefully in a minute. But my point here is that we have to find a way to drive encourage, recruit ethically and morally individuals into these models. And the reason I'm excited about the Biden version of direct contracting as they iterate is it will naturally likely include an equity component in whatever form. Maybe there'll be a one-time fee adjustment, maybe there'll be a risk adjustment. I don't know exactly how the math will work, but the good news is we should have people working to recruit folks from the underserved communities, rural and urban, ethnically diverse, and to bring them in. And they could retain whatever rights they have, which is to see any doctor they want, but to have an overlay. I call that overlay, Mike, a health information fiduciary. And if I were to go back to what is CareJourney, I want to serve as many health information fiduciaries as possible. We should have a massive marketplace who compete to advise consumers on the very best decisions they need to make on their healthcare journey.
Yeah, no, it's so well said, and couldn't agree more relative to the concept that you just described there, especially towards the end. Maybe just pivoting a little bit to a few of the questions that are coming in, because I think they're pretty relevant to this discussion, as well as clearly you have some deep expertise. Some of the questions are around when you started describing FIRE and Smart on FIRE. There's been Apple sort of helped push us to where we are today, and I would argue, and some of our questions are around what does the next sort of leap look like? How do we actually make it go forward? And maybe describing some of the use cases, or even to some extent, what is it and what is it not? I think would be helpful for the group to hear.
Yeah. So, Mike, I think everyone that's been in healthcare data for a decade or more has lived in the world of interfaces. I want to connect to you and share information. And for them, this whole move to FIRE is like, what's the big deal? We're just translating from English to Spanish. I've already got an interface. It talks HL7V2. Maybe that language is a little bit arcane. And so we're going to clean it up with a new language. Big deal. So anyone out there is looking at this like, what? Why is this an issue? Well, that's like the 2% of the innovation is a common language that's in a modern internet, architecture. But 98% of the change is we're moving from interfaces to substitutable apps. That means one connection reused many times versus one connection per use case. Now, there are many companies, and I love everybody, who will say, no, make the one interface to me, and then I'll subdivide. And so there's sort of a kind of a kludge of this, which is like pick the one connector to rule them all, and we'll have a sort of a connector efficiency play. My view is that the road we're on is really about when I build an app, what are the resources I can access to do my job? And so now that we've got this architecture of substitutable applications, not only can you connect to Apple Health or Android, but if VillageMD wants to build a consumer-facing app, you ride the same exact rails, no interface required. Ideally, no registration required. We'll get back to that on the policy side. So now we have a safe, secure, internet-based application architecture that allows for with no barriers to entry, so that we can all compete for consumers' voice. Now, there are limits in terms of what data I can pull. I can't really get much in the way of cancer stage. That's not a thing. So we can get structured data. We'll have raw notes, but over time, we can iterate and say, how do we want to communicate social determinants of health? Maybe we want to have a little bit more structure around food insecurity, and here's how you flag it. Okay, so there'll be iterations on what the supply of data will look like from the proprietary data models into the open data model. Think of it like a Roku channel, where we're going to add 20 more channels in the next 3 years. And we should decide what channels do we want to add. A cancer channel, we want to add a, whatever, orthopedics, device implant channel, whatever. Then we need to expand the uses. It's not just the consumers that want to log in to apps. Doctors want to log into apps. Health plans want to log into apps. My health information fiduciary might want to log into apps. So we've got to create governance at the application registration layer that is scale from traditional business to consumer to B2B. And so if we think about these as knobs and dials we can adjust, we don't need to have a whole new debate for 10 years for what FHIR 2.0 is. It's an ever evolving. The price transparency rule is coming. Where's the command that says get price for back surgery? Well, what's the command? What are the definitions? And then what would the response be if I asked? So we're going to iterate that way. And Mike, the answer to me is we've got to continue to build consensus on the same open stack. We don't want to have a public health data stack over here, a price transparency stack over here, the clinical data stack here. We've added complexity. So my objective is reuse, add more resources, expand the governance, and we can standardize off of the regulated substitutable applications that the information blocking rules is going to scale between now and next December.
Yeah. I complete the way that I think about it is it's all about the democratization of the data and the connections such that the innovation can happen really at the point that it needs to happen closest to be it the physician, the nurse, the patient, whomever. And so I'm really excited about where it's going. Maybe a couple, well, before I get to that, you mentioned something just now relative to what's happening over the course of the next year. I mean, I think these things it's so easy to just say, oh yeah, that's just happening now. But I think some of these things are so seismic in terms of the impact that they can have relative to open data across the sector that is healthcare. Maybe it's just describe like, what is that? So people have an understanding of really what's to come as we think about open standards.
Here's the quick timeline. Last month in April, every doctor has the right to give a list of their patients to the local hospitals, even the ones that you don't have privileges in, to say, if you see my patient, you got to send me a notification. That's now a right. And if the hospital refuses you as a physician, they can be licensed and sanctioned out of the Medicare program, which is essentially a death sentence to say policymakers are serious. Hospitals must share real-time notifications to doctors. 1, that's live already. 2, July of this year, every government-sponsored plan, Medicare, Medicare Advantage, Medicaid, healthcare.gov, they will have to provide the same consumer-facing patient access API to not only include the claims data that they've been generating, the residual of all the encounters, but actually all the clinical data that they've been collecting, the lab values and others, package it up and make it available to a consumer. Again, no fee, no registration required, just an open source process. Then as we evolve into 2022, CMS is expecting EHR vendors to ship the Smart on FHIR protocol no later than December of 22, but it's already getting rolled out now. That has 2 fundamental features that I consider to be, to your words, seismic. 1, it empowers physicians who purchase these EHR systems to select any third-party app that meets the Smart on FHIR protocol, a VillageMD sponsored app, and install it natively in their EHR without having to go through a huge third-party fee gateway app store. The doctors have rights to install apps on top of the EHRs they've purchased. Number 2, we introduce a new technology, which to me is the ball game and is taking the single patient FHIR payload and aggregating it at a population level called bulk FHIR, or anecdotally push button population health. This means every data sharing contract from next fall on will be negotiating bulk FHIR rights. Here are the list of patients I would like to pull out of your EHR. Here's the list of patients I'd like to pull out of your health plan system. Here's what resources I can access whenever I want. Here are the resources you can access. And we're going to update this every 90 days or yearly. Just that's it. A, B, C, go. That's the data sharing. No more months and months of waiting for interfaces and security reviews. It's like, this is the machine. The machine can do this. If we agree to negotiate this data sharing terms, execution of that should be super straightforward. That is what excites me, because most of the waste in our administrative systems today are gobbling up all this random data, trying to make it common and consistent for whatever purpose you're looking to do, scoring on quality, looking for cost savings, whatever the issue is. That's coming. And if we get our act together now, we can demand that the payers and providers implement this. Like, who's the Apple Health for this bulk fire application use case? It ain't going to be Apple. So who's going to step up to represent? I say VillageMD, or someone else in the Matter ecosystem should step up. Right, Stephen? So that's what we're going to do. We're going to bring this new muscle to life thoughtfully so that we have the information that we're going to need to be successful. Now, there are other rules that are coming. Price transparency rule across the next 12 months, implementing the good faith estimate. So doctors have to know what the anesthesiologist fee is, and others to like send the pre-bill to the plan to get the estimates. And so we're going to have more quote unquote shopping potential in 12 months, as also payers have to talk to payers, and there are other use cases that are coming, but these are big building blocks. The single consumer fire to bulk is the biggest that I'm focused on.
So maybe I'll give one. I have two questions. Let me go back to payment models. So we talked about this innovation coming through the lens of CMMI relative to the newer program that is currently DCE. But think about payment models in commercial plans or PPO plans, things that are happening sort of more broadly for the broader population, albeit moderately healthier, but that's still really dense population. What kinds of innovation, what kinds of changes as you think about that area of the healthcare domain would you see coming, or would you hope you would see that would happen?
To me, I think the digital front door virtual telemedicine concierge chassis is ripe for scale in this commercial value-based care model, because it would encourage and in fact recruit partners who are going to compete to earn your trust, to bring you in early for consideration and triage you. The ideal scenario is we went down the narrow network road, and there's a future for that when you can't afford anything else. The real magic is, can we improve navigation in an open choice world? And the large employers in Medicare are actually, I saw an email about Amazon, Berkshire, Morgan Stanley. I tell you, nothing beats the common challenge of driving value-based care on an open network. You can't constrain choice. You can't limit with prior auth. Can you introduce a more actively engaged opt-in approach? If it works for CMS DCEs, it should carry over philosophically into commercial PPO. And so that's why I'm very excited about this. And I think the CMMI team, Liz, has said she wants to collaborate with employers in the next generation of models. So that is where I'm eager. And we learned something new for the first time very briefly, Mike. 15% of original Medicare patients estimated have a retiree plan sponsored by their employer. So there's an interesting nexus, which is how do we get employers to route their retirees into a VillageMD direct contracting entity? No pressure on anybody else, but I love you and I love the team. It can be anybody, SchmilligeMD, whatever. But we could do that, right? We could encourage retirees and employers to participate, and then carry the learnings into their commercial offerings as they go. The roadmap is in front of us, Mike. I'm so excited. We're going to bring the country forward together.
We are. So let me ask my last question. I'm going to bring it back to entrepreneurship. As hopefully people can tell, we were very fond of each other. But that said, I didn't know you when you were 25. And I would love for your perspective on, if you went back to the 25-year-old version of Aneesh and had one piece of advice to give him, what would you say?
So 25-year-old Aneesh thought we could accomplish a lot more, a lot sooner. And I think 48-year-old Aneesh would say, change takes time. And so, you may be enthusiastic and excited and you can see impact, in days, weeks, and months, but we're going to have to see impact in years. And so you might want to plant more seeds that are baking for a multi-year change than to hurry up. And that's been a challenge for me. I see Ed Simcox, former HHS CTO, on the Q&A. Love it. Love that we have this bipartisan spirit. And Ed is raising the same question, Mike, maybe we could iterate out on here, which is, the 25-year-old Aneesh might have also had a little bit of a lack of market sensitivity, which I didn't quite appreciate. There's all these, entrenched interests with Byzantine economic models. And so the obvious, but why don't we just do the obvious? Well, there's many structured things. And so Ed's describing an example where even the government itself is sort of entrenched with some of its, overspending on relatively average to not so great, capabilities. We've got to get a culture of agile and modern frameworks in place. So 25-year-old Aneesh should have been a lot more market sensitive about how to understand the Byzantine nature of the market and to find ways to work, unwind some of that to drive some of the change. But we're here now. We're going to make a great deal of progress, and I'm grateful and hopeful we can do more of it together. So thank you for the chance to join you today, Mike.
Yeah, same here. And just with that, I want to thank everyone for participating. Great questions. Aneesh, it's always a pleasure. I really appreciate our time. I look forward to connecting again soon.
Excellent. Take care, everybody.